Mothers want the best for their children, but what if you were told to wait out your child's condition and hope that one day the condition will fix itself? Beverly is a worried mom who wanted to know her options.
I'm Beverly. I'm Madison's mother. She started walking relatively early at around 8 or 9 months, but we did notice that she had very bow legs. So we went to the doctors to ask them about it, and they said it was normal and that we just had to just sit and let her hips naturally rotate.
So tell me a little about her history.
She was very bow-legged when she started walking, and then as her legs straightened, I've noticed that her feet have begun to turn in.
This is the most important thing that you could do for your child, is early intervention. The sooner we start, the more conservative the care, the easier it is to resolve this problem. So let's do a quick physical examination, take a look at her legs and her feet, watch her walk, and look at the x-rays and decide which route we need to take to treat her. 1, 2, 3, go. And now come back down here. You did great, yay. All right. And when you see the foot and you look at the metatarsals, you see that they're put inwards. What it tells us is that she's developing with that pigeon-toed or in-toed gait. So we need to do something to impress the straightening of these bones. I really feel at this point we would benefit from pursuing a conservative option. I think a custom-made orthotic for her shoe is very important. It will keep her legs straight so her metaductus can resolve, and that her ankles, her knees, and her hips will continue to develop straight as she grows.
Thank you.
You're very welcome, my dear. It's good to see you. We'll see you soon.
Make me feel much better.
Thank you, Doctor.
We have Beverly with us, as well as podiatrist Dr. Ali Sadre. We're going to meet Madison in just a bit. But first, Beverly, your biggest concern is obviously long-term.
Yes, worrying that this would somehow, hinder her in the future with her walking. Sorry, brought a little tear to my eye. Just her walking, and she moves a lot. She's very mobile. So I feel like she'll probably fall into sports or something very active, and I felt that her feet and her situation might hinder that.
You know, problems like this are actually pretty common. Probably about half of babies are born with at least a little bit of pigeon-toeing or in-toeing, but it's usually flexible, and those kids are going to outgrow it. But what Madison had was a little more rigid deformity of her foot. It's called Metatarsus Adductus, and it happens in about 1 in 1,000 kids, mostly in females.
And who's at risk for this, Dr. Sadre?
Well, you find this mostly genetic, so it's an inherited deformity. The intrauterine forces, meaning the kid's position in the uterus, can also affect this, and the developmental changes, so the activities they have as children, can also affect this and make it worse. As Dr. Sears put, they're born with it, and we can make it worse or better based on what we do. And
Beverly obviously saw some warning signs. What are the other warning signs parents should be looking out for?
Well, in the beginning stages of walking, if you see obviously in-toeing or stumbling over their toes, not wanting to walk, having it difficult putting on the shoes because the in-toeing is so aggressive, these are things you want to look for and not overlook.
So, since it's not that uncommon, what treatments are there for this condition?
Well, the treatments have changed. In the traditional way, we used to have these braces, the Forrest Gump-like thing, or these braces that we put bars on the feet, or even the old-fashioned treatment of giving reverse last shoes, switching the shoes from left to right. And those help these metatarsals. This is a Metatarsus Adductus example, pushing in. They help these metatarsals straighten out over time. But now we have these advanced orthotics. We can actually cast the foot and give the patient an insert, which then forces the foot to grow in the correct direction.
And this is what you decided to do with Madison?
At this point in time, it's the best option for her, actually, yes.
So let's meet Madison.
Hey, Madison. How you doing? Can I get a 5? Oh, thank you.
My Barney too.
Oh, Barney gets a 5? Awesome. That's cool.
So are you ready to try some shoes? So these are the shoes that you designed with the inserts, right?
Yeah, so the orthotic has to fit inside the shoe, nice and stable, so you can actually control the step tail. And I'll give this one to Dr. Sears.
Here comes your new shoes. All right.
And so these will control the subtalar joint when she walks, so that as she walks, these flexible bones, which we've talked about, are mostly cartilaginous, will start to grow the correct direction. Like bracing a tree when you first plant it. It impresses the foot to grow the correct direction as she develops.
All right, Madison,
Let's
ready?
try these out. So the hope is with these inserts, no need for long-term either surgery, anything greater than just inserts until her legs are fully developed.
That is correct. It's very important to follow up frequently. We'll see the patient every couple of months in the first year until we have definitive changes on the x-rays, and then we'll see them every 6 months, and then we'll see them every year. So we'll watch the deformity actually develop out of the foot. Very effective treatment.
Thank you, sir. Thank you, Beverly.
Welcome.
Thank you, Madison. Thank you. The next time that you go to the dentist, should you worry about getting your cavity filled? Find out the answer next on Prevention Magazine's Health Hearsay Edition.